We'll continue now talking about function with Dr. Linda Woodhouse.
Thank you, and thanks to the organizers for inviting me here today. I also hearken from University of Alberta, and my task was to talk to you about measuring function. And I want to say that with a caveat. 20-some-odd years ago, when I first stood up in front of a group of endocrinologists and started talking about function, 3 or 4 minutes in, a brave soul at the back put up their hand and said, "What organ are you talking about?" And I said, well, I'm not talking about an organ. We're talking about moving in three-dimensional space. So I am a physiotherapist by training. I'm also an exercise physiologist. And so I come at this very much from an orthopedic and endocrine world, and we'll try and apply that and hopefully be helpful. My other comment is I sat through many of the presentations now, including Vicky's, and it made me think that do we really need more evidence or do we need more implementation into clinical practice that changes? I can't imagine data from 100 years ago on body surface area is better, or there was more data than there is on what we already have today. So with those caveats, these are my disclosures. I do myostatin clinical trials with a couple of drug companies, and as a physiotherapist, I'm involved with a couple of companies and the American Physiotherapy Association creating outcomes registry, and that's to measure physical function across various populations in the United States mostly and across Canada. I want to take you through a whirlwind tour of my world to sort of say what are the benchmarks and biomarkers that we already have in place for sarcopenia, how do we actually conceptually measure function, and talk to you a little bit about self-report compared to performance-based measures that I think are really important to distinguish between. I'll then turn my comments to, and I think others have already said this, it's not a sentinel muscle, it's not a sentinel measure, it's probably a battery of measures that we need. So this has been well defined by all of my colleagues who've gone before, that sarcopenia was loss of muscle tissue, and it was associated very much with aging. And then from the work in Europe, they came along and said, no, we're going to describe a syndrome. And that syndrome includes not only the low muscle mass, but also low muscle strength and or changes in physical performance. But what do we really mean by physical performance? If we look at the mechanisms of sarcopenia, and what we see is that the primary reason it might be aging, but if we think of cancer and cachexia, the disuse atrophy that occurs, the inadequate or change in nutritional status of individuals, and I point out the hormonal regulation and other diseases all factor in to sarcopenia as well. And so I think to the comments made before about the multiple hits that one gets, the cancer and cancer treatments affect the endocrine and neuroendocrine system. The cancer and cancer treatments affect our ability to take in and use nutrition. They also affect the amount of activity that we do on a day-to-day basis. So all of those lead in, and that's why I think a multifactorial disease needs a multifactorial approach. You've seen these before, and it's just to point out that, yes, in the lower extremities, quality of muscle matters as much as quantity of muscle. And we're very concerned, and way back when I did testosterone dose response studies, we saw these changes not just with aging, but also with change of using a GnRH long-acting agonist in combination with various doses of testosterone. And you could get up to 3 kilograms and 3.5 kilograms gain in lean body mass, but also increase in fat mass for those individuals on low doses. So it's really important to think not just about the quantity of the mass, but the quality as well and the intramuscular fat. I've seen many MRIs and CT scans of individuals in their 80s who continue to compete as athletes and would look more like the top figure than the bottom figure. We also have to think about if we're designing trials with endpoints that include muscle mass and strength, what about physical function? And what are the implications, the metabolic complications associated with cancer and some of the treatments? And how do we evaluate those? So one might want to address fatigue and ability to move long distances or walk to the store or get groceries and be independent with their living. And that's more on the aerobic side, and metabolism becomes more of an issue than simple grip strength or muscle strength per se. What biomarkers are used or can be used to identify sarcopenia? The holy grail that we're chasing, I think, or trying to chase, and I hearken to Vicki's comments about maybe not setting specific cut points, is biomarkers for osteoporosis. They look at bone mineral density, and they associate that with falls and fractures and the composition of bone. I think we're dealing with something very different here, and that is that you have lower muscle mass, you have changes in mass, you have changes in quality of certain muscles that may be very different. We have androgen-responsive muscles, say the quadriceps and the proximal musculature, which are much more responsive than, say, the psoas or peripheral musculature. So I think we need to be more selective about what we're trying to measure and why. The quantity, many have said, can be done by various imaging analyses. The strength, and I see much of the literature working towards not lower extremity strength, but the quality, the muscle strength as far as the upper extremity. And I'll maybe not share some of the work that you've done, Peggy, with Shelley Bassine, who I'm working with now and have in the past, and that is that the arm ergometry is probably, or muscle strength of the hand grip is probably an appropriate measure. But in my world, what if the patient walks in with sarcopenia that is also sarcopenic obesity with osteoarthritis of the hand or rheumatoid arthritis? Now I need to go to a completely separate measure. Most of us use gait speed for mobility, and that's, again, walking and functioning in the real world. The European group said we need to define sarcopenia. So what they came out with, and I think it holds up today, is low muscle mass in combination with low muscle strength and or low physical performance. If you have all three, we'll call that severe sarcopenia. But in terms of the clinical application of this, they reversed it, and I think quite rightly, to say, let's measure activity levels or gait speed first. If an individual has adequate gait speed, which was defined as greater than 0.8 meters per second, then we would move to evaluate their muscle strength. If they're okay there, they don't have sarcopenia. If they're not, then we'd go on to evaluate muscle mass. So for clinical operations, they reversed the order of that. They also gave us lots of different ways, and we're all familiar with how we measure things in research, and the red box is how we typically see things measured in clinical practice. FNIH then looked at the same type of thing and said, could we identify cut points for that? And develop cut points for grip strength of less than 26 kilograms for men and 16 kilograms for women for grip strength, low muscle mass, which is appendicular lean muscle mass for men and for women. So at least we had some idea, albeit not perfect, of the cut points. Now, if I think back to my world of how we measure physical function in physiotherapy and people moving about in the real world, we use the ICF model. It used to be impairment, disability, handicap. We're much more friendly in terms of our terminology now, and it's an international classification of function, disability, and health. And the two areas that we're really focused on then are body structure and function is all that we're measuring when we think of mass and measures of strength like grip strength. To get an activity-based measure, we move to gait speed. Okay? So the relationship between these two in many populations, orthopedic, cancer, rheumatology, infectious disease, inflammatory disease processes is really weak correlations between those two at best, which that's why we need to measure measures from each of those two categories and not try to get one measure to be the be-all and end-all and the sentinel measure for everything that we're doing. So why do functional and physical performance measures? And I get asked this a lot. Way back when I had a colleague who sat down and said, Linda, you could do a quality of life measure, or you could do something that a patient fills out, and the domains are so much broader for what we evaluate. Why do you have to walk them up and down the hall and do these gait measures? It's difficult to do in a physician's office, et cetera. So let me walk you through the arguments that we had and the data that we came out with and why I think it's important to actually do both. We use measures of function to discriminate functional status, and that's what you've seen with the sarcopenia criteria. We use them to predict subsequent function, and in this case survival for cancer patients or those individuals who have survived the cancer in their treatment and are going on now to what we would consider to have a chronic disease, as well as, and I'll spend some time to look at how you use them to evaluate change in function over time, where the measure has to be not only valid, but reliable and sensitive to the change that you're trying to measure, be it an intervention or the change in the individual's functional status. So you've seen lots of these graphs today. This is another one where non-small cell cancer, where they actually looked at a cut point of 400 meters to predict cancer survival, how an individual would do with chemotherapy and other treatments. And for those of you who aren't familiar with the 6-minute walk test, you walk as far as you possibly can in the 6 minutes. And typically, individuals who are healthy would be somewhere around 650 to 700 meters in that 6 minutes. We also know from the NHANES study about cancer survival that if we look at a shorter physical performance battery, so these are tests of balance, standing balance. They are tests where you rise and sit down again in a chair 5 times within a minute. And walking short distance, 4 meters for gait speed, as well as the fast walking pace. In this case, it was more than 6 meters per second. And what you see is that those physical function measures relate to survival and can be used to predict subsequent events. So how do we evaluate then change in function, which I think is of more interest to you in terms of the interventions that you use? We have to think of the appropriate mechanism and the time course of the adaptation to the intervention. Time and time again, I see people picking a measure because it's easy to do in an office and an office visit, and it's quick to do, but it doesn't necessarily relate to the physical function that the patient actually wants or struggles with, and it doesn't necessarily relate to the intervention. If your intervention is going to improve, say, oxygen flow to muscles, you want to measure something on the aerobic side. If their interest is to reduce fatigue, to make it through a day, you want to intervene with aerobic and measure that. If, however, they're interested in getting out of a chair and they simply don't have the strength to do that or to transfer independently, then that becomes a strength issue. So I think we need to be clear on what we're measuring and why. So I would argue that measures need to be not only disease-specific, but also condition-specific. And I'll use an example from total joint arthroplasty to show you that data. And as I said before, we need both self-report, so that's the patient-oriented outcome measures that you see now, a pen and paper task that are specific to questions about function, not necessarily the same as quality of life. And they are different than physical performance measures. So this is a sample from about 2,000 patients that we originally did, and a series of trials have been done since, where we looked at a lower extremity functional scale, takes less than 2 minutes to fill out, widely used across ambulatory care centers and inpatient centers for patients of all different types of disease, stroke, cancer, you name it. We looked at performance measures that we did, a self-paced walk over 200 meters, timed up and go, where they rise from a chair, walk 3 meters, come back and sit down again, that's timed, and a stair test. And what you see is there's moderate correlations at best. The same is true if you look at cancer. And so what does that mean? If it's moderate correlations between actual performance-based measure and self-report measure, then they're telling us different things, and we need to measure both. More importantly is probably these series of studies, and there's been a number since. And that is that the 2 bars on the left-hand side are the WOMAC. It's a disease-specific questionnaire for physical function related to osteoarthritis, and the SF-36, the physical function submeasure, compared to gait speed and 6-minute walk test. So while the patient's perception is that their performance had improved, and that's what they reported on the questionnaire, in actual fact, if we measured gait speed and 6-minute walk, they've gone in the opposite direction. And that's why it's crucial to measure both, because they're telling you different things. The next question I often get is, how do I really know that the change is important and real? there's two things that you'll see in the literature, often used interchangeably, so I just want to clarify them for you. One is minimally clinically important difference, MCID. They are anchor-based, so I might do a 6-minute walk test, and I measure how far the person walks, and I do that pre and post an intervention. But I will also ask them, do you perceive that you're walking better, no change, or worse? I might also ask a spouse or a family member to rate the individual. So there's a global rating of that activity. And that's what you use to calculate your MCID, and that's why we call them anchor-based measures. Now, these are very subject to something we call response shift. So as a person's function declines, their internal value and set for understanding how they're performing in the real world and walking functionally, getting around, changes over time. And it changes, at least we've measured it in orthopedics for total joint arthroplasty, about every 6 months. They reset their expectations. So is it that we want the patient's perception of function, or do we want the actual performance-based measures? And I would argue for doing both. You'll also see MDC. That's minimal detectable change. So how do I know that the patient actually improved from pre to post intervention versus simple measurement error? And this is a mathematical calculation that's distribution-based, based on the reliability of the measure and the standard deviation or standard error of the mean. It's a calculation. And I would argue that performance-based measures, where many go back to an anchor base and ask the patient's perception, which I just told you with response shift changes over time, that we really should be for cancer patients and patients living with cancer and surviving cancer, that we should be looking at MDC and what the actual distributed-based measures are. We've looked at growth curves for 6-minute walk tests, and it's similar to what you saw this morning. Males and females on almost all performance measures are different. And there's an expected trajectory for us of recovery that we know what we would see. If I then look, and this is just males alone, what was the pre-op functional status or the pre-intervention, in your case, functional status? That often dictates the trajectory of the recovery for an individual. So it's really important to measure them before and also after your cancer intervention and treatment. The other thing to note is the MDC for us in total joint arthroplasty, almost everyone, even orthopedic surgeons, if you ask them, they know the value of 61 meters. So if I measure a patient's 6-minute walk test and they can do 250 meters, they come back after an intervention and they're 300 meters, I know that that's a 50-meter change. It's not enough change to say that it's beyond the measurement error of the test. I also know that the MCID, so for cancer and COPD patients, we've asked spouses, family members, and the individual whether they perceive an important change, and that's somewhere around 54 meters. I think sometimes the intervention trials are actually too short a window and maybe not intense enough or large enough doses of particular, if we're looking at myostatin and other anabolic agents or other treatment agents, they're not large enough to actually get some of these changes. And I think in shorter duration trials, and specifically in patients with cancer, we need to go back and calculate some of these. These are just some of the measures. So we anchor any of the performance measures that we do to say individually, has a patient improved or not? Will I continue with this treatment? We anchor them based on the MDC 90 evaluations. Just want to walk through for a couple minutes quickly the functional capacity of individuals. There's tremendous variability based on gender, based on age, based on physical function, how much people exercise and work out over time. We also know that something happens, as Vicki said, and the individuals may lose their functional capacity. We use the threshold of functional independence, the ability to get up and move around in the real world. With this large span, and there's different trajectories of recovery from that. Well, more reserve capacity you have, that's your maximum compared to the threshold for functional independence, the greater that difference, the more insults you can take before you tip over to have functional decline. We need to consider the longitudinal measures that are done and avoid floor and ceiling effects. By that I mean, if I'm testing an athlete, I can't simply do a timed up and go to walk 3 meters. The ceiling effects will be so large that I can't measure that person prior to, after an intervention or treatment for cancer or surgery or other, and then recovery. So I need measures that are going to be over a prolonged period of time, pre, post-intervention, and out 5, 10, hopefully 15 and 20 years. Okay? The other thing I just want to mention quickly is if we look at the change either with surgery or an intervention, there's a functional decline, and the responsiveness of the measure, if I measured 6-minute walk test here, I wouldn't see any change perioperatively or in close concert to treatment to a cancer therapy. The measure I need here is going to be very condition specific. For us, even with the same disease of osteoarthritis, a stair climb measure is much more sensitive to change for total knees, and for hips, we use the tug. But for the broader continuum, we use the 6-minute walk test. And this is just the data to show you that. Why do we anchor these measures? I just have 1 or 2 minutes. Why do we anchor these measures in tug? 30 seconds to do a tug means that the patient is dependent on others for their care and transfers. 10 seconds or less, they're completely independent with their living. But as I said previously, the hip patients, this is quite a responsive measure perioperatively for us, but it's not if I measured pre-intervention and say 6 months to a year post-intervention. I would get ceiling and floor effects, and I wouldn't be able to measure anything. And that's why we need, I think, a battery of measures. My last comments relate to Peggy's work with Shelley Bassine and others, and that's the international group flipped the question around and said, do the diagnostic cut points that we're currently using for low muscle mass and strength actually predict, they've called it mobility disability, I'd probably call it mobility limitation. And what they've done is analyze, and Peggy's gone through all that, and I don't want to steal their thunder, but the bottom line, I had a long discussion with Dr. Bassine the other day, the bottom line is that the muscle mass didn't really correlate very well with mobility disability in all those trials. The grip strength, absolute or scaled to body mass index, actually did predict mobility disability. And I think we need to do more of that, and we need much larger pragmatic trials to be able to measure the disability associated with the interventions that you're going to use. So just to summarize, I think we need to do measurements of activity and physical function, not just structure and function that we're doing now. We need to have both self-report, that's patient-reported outcome measures, and performance-based, and they need to be condition-specific. Muscle strength is probably closer to mobility in that continuum than is simply mass, but I'm not saying you do it instead of, I'm saying you need to do these measures in addition to changes in muscle mass. And I think we need a composite evaluation. I know it's nice to have just 1 or 2 sentinel measures of muscles, but I don't think it's enough. I think we need a battery of measures that if we consider an aging population, other comorbidities, hormonal dysregulation that's going to occur through the cancer and cancer treatment, we need a battery of measures that tells us the direction that we need to go to be able to clearly evaluate our intervention. Thank you.